Hey, and did you know I'm currently accepting new patients in New York, offering both in person and telehealth visits? And I also provide telehealth for patients in Michigan, with North Carolina coming soon. And I also offer coaching, both intimacy coaching and menopause coaching, nationally and internationally. So look us up on www.femvhealth.com. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about male sexual dysfunction and male sexual health. Before I get into it, of course, as always, we are not giving any type of medical advice. So if you have any concerns about your health, make sure you go speak with your friendly neighborhood urologist. And if you have any questions about your religion, make sure you go speak with your neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So today I'm super excited to have on with me Dr. James Kuan. Dr. Kuan, if you could please introduce yourself to all the viewers and listeners out there.
Great. Thank you for having me. My name is James Kuan. I am a urologist in Seattle. I have 20 years experience in men's health, specifically sexual dysfunction, and I'm also the creator of a newsletter called Sex After Retirement, where we cover issues of sexual dysfunction, erectile dysfunction, intimacy, relationship, and then also aspects of recovery after prostate cancer, like impotence, like incontinence, and then just things about how life is changing for men.
That's great. That's fantastic. And, that is definitely one topic, especially male sexual dysfunction, that I don't cover very much because I'm a gynecologist. So I don't really talk about male sexual
We're
dysfunction.
neighbors. We're neighbors.
That's right. That's right. We sure are.
Yeah.
So let's get into some of our topics. So what drew you into urology and specifically men's sexual health?
I think I have a story like lots of urologists. Urology chooses us. My 16-year-old self could not imagine what I do today, couldn't have imagined me getting into urology. But it was an experience with urologists as a medical student, and that moment saying, I could do that. And then the typical things like good mentorship in residency and sort of the usual things like technically I like the operations that come with men's health. But this move and this growth through my career into sexual health was really about seeing that there was a gap, as I think you have also, a gap because of timing, because of culture, and because of interest. Talking about sex is not always sexy in medicine. People want to be doing procedures and operations, and a lot of what we do is not that. But the real art and the charm and the allure for it, to me, was to fill that gap where information wasn't there. And then the other thing is I was part of the sexual revolution for men. I graduated medical school in 1999. Viagra came to market in 1998. And so when I was a resident with that mentorship, I was finally seeing that there was something that could be done, at least mechanically, getting the erection there. But I've come to learn through my experience that it's more about conversations and information. And so being able to make that change to give people what the World Health Organization guarantees all of us is a healthy sex life as a human right. I get to be a player in that, and making people feel comfortable with these topics, as I know you do, is really rewarding for me.
Yeah, 100%. I mean, just like what you had noted is that you were filling in a gap. And that was absolutely what I saw when I started this podcast, about 5 years ago. And it was really about creating that sex positive environment that I didn't have growing up. And really about changing the narrative about how people see sex, see Muslims, see, just all the cultural baggage that sometimes people can carry with them, and changing the narrative for the next generation. So I really appreciate what you do. Why do you think men struggle so much about sexual dysfunction? And why, just to kind of add to that, why do you think it's so difficult to talk about, right?
I think that there is very few things like sexual function, and I'll say that instead of sexual dysfunction, but very few things that sit so closely at the intersection between their physical function and their identity as men and masculinity. And I'm not going to talk about all these models of masculinity, but it is so personal and it is so tied to identity more than anything else. And so I think that men who are moving into discussions about sexual dysfunction when things aren't working are really tiptoeing out of that identity that culturally and personally they hold very dear, into a space of vulnerability where most men haven't always seen people be without ridicule, without comment or joking, the typical reaction to a guy saying, "I just can't perform."
Yeah. Yeah, absolutely. Absolutely. And so, what are some of the most common concerns men bring to you that they often suffer silently for years?
The thing that always breaks kind of my heart is the guy who's had his prostate removed for prostate cancer, who has been taken care of in part by a very good urologist who probably cured him of his cancer and has told him over and over again that the surgery was a success, and the PSA, the blood test that says the cancer is gone, is zero. And so on that one front, things are successful. But he also feels that he wasn't prepared for the life that came after that. And so those men often wait in silence, and it's part of why the newsletter is there, because some of those people come to me never having been told about the things that we can do to fix their dysfunction. And then just ED in general. The average guy waits 2 to 5 years before seeking real help, not help online, not help on a Google ad, not help from a text from his best friend. But they wait, they suffer in silence, and they keep looking for solutions. And they use that, the searching for help themselves, as a surrogate for actually getting real help.
Mm, yeah. So, how much of erectile dysfunction do you think is physical versus psychological?
Well, I referenced kind of the release of Viagra in the late 90s. And before that, we used to think that it was at one point 90% psychological, 10% physical. And that transition went to 50-50. And we're really at this stage now where 90% of erectile dysfunction is physical.
Mm,
And 10% is probably that pure psychological. That's not to say, though, that a guy who has erectile dysfunction, even one time, because of a physical underlying cause, doesn't very quickly move into that psychological phase of it's just one more thing tipping the scale out of his and his partner's favor.
yeah, I'm sure. I mean, we know that so many things in sexual medicine have, the biopsychosocial component to it, right? And so I'm sure, like you said, 90% of erectile dysfunction is physical, which I had no idea that it was so, the percentage was so high. But definitely I'm sure that, psychological component is also there. And I think that sometimes, and you correct me if I'm wrong, but sometimes men are so worried about performance and that gets into their head so that the more they worry about it, the more difficult it is for them to have an erection because they're so worried about the erection happening. What would you say?
Well, that and there's physiology to that. So there's the embarrassment, the avoidance, the is it going to happen? Is it going to happen? You will agree, when we worry, we get adrenaline rush. Our heart rate goes up. But the other thing that happens is our blood vessels squeeze. For a
Mm,
normal erection to happen, blood vessels have to relax. Adrenaline causes blood vessels to squeeze. And so this spongy vascular tissue, which is supposed to fill up so much the shape of the penis traps that blood so that you have a rigid erection is working against itself by squeezing, and that sponge stays dry. And so that, is it going to work? Is it going to work? That anxiety in and of itself becomes, in the moment, probably the more significant risk factor for someone who's already experienced some ED.
Sure. And so, what do you wish women understood about how ED affects men emotionally? I'm sure it affects them a lot. I mean, in so many different ways.
Yeah, I think it's that I think there's a scenario that I would create that that a lot of couples experience, that women initiate a bid for connection, maybe with the anticipation of intimacy, and they experience their partner withdrawing from that, and what they make that withdrawal mean. Um, is it about them? Is it about her? When in fact, my observation and what I hear from my readers and here in the exam room is they're really withdrawing from the potential for failure.
Mm,
That gets to their ego. And we can say, well, they need to just get over that. But men who are providers, men who historically maybe have been able to participate in intimacy, really struggle with that. And so men don't want to fail. People don't want to fail, but it sets up that failure loop. And if I just kind of get busy, it's the I have a headache tonight, because I actually don't want to. I want to have intimacy, but if I fail, then I'm confronted with that fear of feeling ashamed, and so the distance grows. And so I think it's really that they're not withdrawing from her, they're drawing from that potential failure.
mm. Yeah, I like that. I like that distinction. That's really important to know and understand. And so I feel like you kind of touched on this right now, but how does erectile dysfunction impact relationships and self-esteem? I mean, I'm sure it's, you know, affects them a
Well,
lot.
I think further to that, if we get into that failure loop and the communication isn't there, you know, she starts to think, well, it must be that I'm getting older. It must be
Yeah.
that I'm not the woman I was when we married. It must be that he no longer finds me attractive, or he must be interested in someone else who's much younger. And I understand that cascade, but it's really, when we don't talk about it, when we don't name that this is physical, it's not about desire. Um, but it becomes about desire. And when we don't talk about that, because we want to be sensitive, we create silence. And I want people to know that the silence is optional. And the having the dialogue on one hand in her head and the dialogue of failure in his head just creates a greater distance. And it just makes silent the third partner in the silence the third partner in the relationship. And
Yeah.
that's where misunderstanding grows.
Yeah. I love that you said silence is optional, right? Because we know one of the most important factors for female sexual satisfaction is actually communication. And so when that silence grows, right, it can cause resentment, it can cause anger, and then it just continues to pull that relationship apart, which is really, really unfortunate.
And I think when we understand that this is physiologic, not just for the man, but for the woman, and the changes that are associated with perimenopause, menopause, aging, delivering babies, and all of the procedures that happen in their lives, that maybe create pain or a sense of avoidance there. When we're both actually speaking about what's actually happening, we can hopefully move past some of the insecurities that keep the silence in the relationship.
Yeah. Yeah. So, what are some of the biggest myths men believe about erections and aging that you've seen, that you've heard, that your readers have written?
I think myth number one is that they're the only one experiencing this and everybody else is still performing as a 10. But 50% of men in their 50s, 30% of men in their 30s, 70% of the men in their 70s have some erectile dysfunction. I think they also feel that there are no solutions. I think they get solution fatigue by trying to find their own resolution online through kind of all the quick fix, all the hype, all the just do this one thing, the optimization stuff that didn't work for them. And so I think they get fatigued. I think they think that it's only about sex and desire, as we've already talked about. And then I think that just that there are no solutions and that help equals failure. And I recently explained to someone, when you were 35 and went golfing, you walked the whole course on your own and you called that golfing. And at 65, you use a cart now. We still call that golfing. And so using the cart to help you because your knees or your hips are bad still lets you golf. Using a medication or one of the other things that we can use for erectile dysfunction to allow you to be intimate is still being intimate. And it's not a failure.
Yeah, yeah, I love that. I love that reframe because I think it's really important for people to see that, right? That if you need help and you're using something to help you along, it's not a failure. It's just an adjustment. So at what point should a man seek help instead of ignoring their symptoms?
Well, I think sort of the important thing is there are one-offs. If there's young couples listening and there's a few occasions here and there because of work-related stress or family stress, and it's an occasional thing, or there was a night out where someone had too much to drink and couldn't perform, those situational episodes are probably not an issue. But when it is a pattern and when it is something becoming something that the couple is having to deal with because things just aren't working, I always want people to address it before it consumes the relationship or either partner's time trying to find a solution or trying to find an explanation that fits, that doesn't feel hurtful. But when we think that erectile function is a symptom of a vascular disease, we need healthy blood vessels, we need healthy nerves, we need healthy hormones. The penis is really the canary in the coal mine. Penile blood vessels are fractions smaller than the blood vessels that supply oxygen to the muscle, the heart muscle. And so the same hardening of the arteries because of cholesterol, diabetes, high blood pressure, and smoking that builds up and causes angina and heart attack. The angina of the penis is mild erectile dysfunction. And over time, those arteries obstruct sooner. And so as it, as to the women listening to this, if your partner is experiencing this pattern in your relationship and doesn't have a primary care doctor to say, what's their blood pressure? Are they diabetic? What's their cholesterol? This is that moment to support them. It's also that moment to understand that all of these things, the march of life, lead to hardening of the arteries. And so there is something physical here. And the longer we wait, maybe the more resentment and silence that builds, but also we may miss an opportunity to intervene on kind of keeping the heart healthy. I always say what's good for the heart is good for the penis.
Yeah. Yeah, absolutely. I mean, you could be saving somebody's life, right? By figuring out that if they have erectile dysfunction, to definitely go to a cardiologist and get their heart assessed.
100%.
Yeah, yeah. I like that tagline. What's good for the heart is good for the penis.
Yeah. In maybe lots of ways, but we'll leave that.
So you specialize in sexual issues after prostate cancer treatment. So what are men often unprepared for after surgery or treatment?
Well, this is not to say that we don't talk about what the impacts of surgery or treatment could be, but we get caught up in here's the cancer, here's what it means, and here's the most effective treatment, or let's compare treatments. That oftentimes when the primary goal to cure the cancer is the primary goal, we hear those things, but they don't settle in. robotic prostate removal has certainly moved the ball, and we're seeing a trend that fewer men are having the urinary complications like incontinence, not being able to control their urine. But still, 10 to 15% of men, even 1 year after surgery, will leak urine. With regards to erectile dysfunction, a lot of that depends on how healthy erections were before, but also the ability to spare nerves. And that relates to cancer, skill of the surgeon, and just recovery. There is no guarantee. And so if we take it to the extreme, we have to understand that erectile dysfunction is possible even after a well-controlled nerve-sparing operation. And I think what people, they hear that, but nobody really prepared for what that felt like. Lots of men with prostate cancer are healthy and productive and have never ever seen a doc for any other problem. And now all of a sudden they're in this spot where something so personal, so impacting of their relationship has been taken away. And I think a lot of men feel guilty for wanting to pursue improved sexual activity when the cancer was cured. And so lived experience is often very different than what we expect. And so it's our job in conversations like this and in the exam room to really spend that time to say that things will change. And I don't do prostate removal, but what I tell my patients as I refer them is, if at some point you feel like these issues are not being addressed to your satisfaction, to address the impact in your life and your partner's life, come back and see me, and we'll address them. Because people need to know there is a progression of recovery, but after some point, further recovery on its own is not likely to be possible. And so helping early helps people restore quality of life, because that's the reason you treated it. Because you have this cancer, and left untreated, it could create other problems. So let's treat it so we can get back to that healthy quality of life. But then, oh, wait a minute, there's this high chance that you'll need pads, or sex won't be the same. And so that can be very alarming when it's actually happening.
Yeah, and I was just thinking as you were talking, do you think that some men perhaps, because they had surgery for prostate cancer, they feel that it's almost, do you think that some men feel guilty asking about sexual pleasure and how their sex life is going to be? Or do you feel that that's just a common conversation and that's to be expected?
They definitely they feel guilty, and sort of the example is when I get to that part in the counseling, telling someone they have cancer and they need treatment, they'll say, "Oh, no, that's fine. We're here to treat the cancer." They're almost embarrassed that I might even bring it up in advance, and I always say, "Sure, that is the priority." But once the sutures are removed, once the wounds are healed, once you're back at work, once everybody stops calling on you to see if you're okay, life goes on. And I think there's also an interesting dynamic that happens in men men's primary confidant is often their partner. And so that there's that dynamic there that they don't want to appear selfish when their partner is worrying about their overall health. Will they survive the cancer? And I think women are fortunate that women have a broader community with whom they talk about more sensitive things. And so there's also that dynamic, because usually the partner's in the room when we're having this discussion. And if there's been a dynamic of silence, if there's been a dynamic of partner having pain and withdrawal, then sometimes those discussions are being swept away from me having them with them. And I'm always going to respect someone's desire to not discuss it further. But it's just, we have to be aware that there's many dynamics, and we have to be open to have those conversations either in front of the partner, in private, or a combination of both.
Yeah, yeah. I'm glad you bring it up, and I agree. I think that a lot of people, may feel guilty. And what comes to mind is, women that have breast cancer, right, and have gone through mastectomies and, a lot of their body image changes, their body physically changes. And so, oftentimes the question of sex doesn't really come up, right? Or they may be afraid to ask, or when they bring it up that sex is painful or they don't have desire, their oncologist or somebody might say, well, we're just happy that you're alive, or you should just be grateful that you're alive, right? Which is
It's a little
really
bit
not.
gaslighting. It's
Yeah,
gaslighting.
yeah, absolutely. So that's why I was wondering if it was similar for men, after they have their surgery and, if they are concerned, but again, they may feel guilty for just having those questions or concerns.
Well, there's data that says that men with ED and incontinence underreport to the surgeon that cured them of cancer. But when they get in front of someone who's offering solutions, will actually say how badly it is.
Wow. Okay.
Because they
Wow.
don't want to disappoint or appear ungrateful.
Sure, sure, and that makes sense. So, how can couples navigate intimacy after prostate cancer together?
Well, I think it starts with understanding intimacy before, a strong partnership with open communication before um, is going to probably carry. But that doesn't mean it won't, because if sexual activity was a part of that, and as I said, partnerships for men often see their partner as their closest confidant. When shame enters that again, that can unsettle that. Um, and any solution for erectile dysfunction, whether it's after prostate or otherwise, isn't going to fix a bad relationship, isn't going to fix the female aspects of sexual dysfunction, right? If sex was painful before, even if you restore it after, sex is still going to be painful for that partner after. And it really gets back down to the communication piece. But I would encourage your listeners, if if their partner is open to going to the discussions about sexual dysfunction or their PSA or their biopsy, to just keep an open mind, to even if they have never talked about these things because sexual function has been fine to that point, just know that it may be fine after, but it may not. And just letting these conversations happen as planting the seed, so that if and when that couple finds themselves on the other side struggling, that it's like, we knew this would happen, but we also know that there's a path forward. And choosing to do nothing is a choice, but seeking good results is also a choice. And that we don't have to live this way. And there are people, it may not be that doctor, it may be your primary doctor, it might be your gynecologist, it might be a naturopath who actually starts moving the ball. Of course, support the partner through the cancer journey and the recovery. But I also think there's this one other thing, and I think it's sweet, but cancer is a big deal. And when someone's been treated with cancer, I think we sometimes treat them as fragile after. And there's all the emotional stuff, but even physically fragile. And I hear not uncommonly from partners that even after they're healed, they're guilty for asking. They also don't want to put their partner on the spot who maybe can't perform, but they're also worried they're going to hurt them or they're going to affect and impact the cancer outcome, and that's just simply not true. And that's probably more dangerous to avoid in a relationship where intimacy helps restore the health of the partnership, to avoid it because they're worried of hurting or injuring their partner.
Right? I'm sure they're probably also worried about like sutures and all of that, right?
Right. And of course, there's that early point, just like, if you were doing a hysterectomy or otherwise, there's that early recovery. But when you give the go ahead, this is you as a surgeon saying, there's nothing that you shouldn't be able to do physically. I'm no longer worried about it ruining the operation.
Yeah. Yeah. So many people don't even realize that penile implants exist. So what are they and who are they for?
So penile implant is not a new procedure, and I think many people are surprised. They were developed in the 70s, and in their initial design concept, they've remained mostly the same. Um, the penis, as we said, is vascular, and so this replaces bad hydraulics. When the blood vessels are bad, we need to fix the plumbing, and so this is an implant. It goes inside the body. There is nothing external. And what it replaces in the penis, there's two cylinders that fill up, causing the erection. And it says what's inside there is not working. So we're going to we're going to augment that with a prosthetic. They're soft, they're floppy, and so when the implant is deflated, the penis is flaccid. And then squeezing a pump that we place in the scrotum, it cycles fluid from a tank or what we call a reservoir and fills up those cylinders as blood would. It really is it's really elegant. It recreates hardness and it's spontaneous. It takes 5 to 25 seconds to completely inflate it. It gets as hard as you need it. It stays up. And so it is in this space of reliability and spontaneity. The people who need it, anybody having consistent problems with erectile dysfunction, could receive it. We often start though with things like pills or even shots, different approaches that are less invasive. But for people who have failed things like Viagra, Cialis, or medically can't take them, or can't use some of the other treatments, or the guy who's had his nerves removed with his prostate, who doesn't want to use a needle to get an erection, is actually a very good candidate. And then there's other sort of reconstructive reasons we use it, but it's really to overcome things like side effects or complications with the other treatments, or just really getting that person to reliability. That every time I want to perform, if I squeeze this pump, it creates an erection. And the only inconvenient part of it is it requires an operation. But once you healed, it's really a game changer. 90+% of men who have it would do it again.
Yeah, I'm sure. And I'm sure, probably psychologically, it's really helpful, right? Because you're not worried so much about performance anymore, about having an erection. You're pretty much guaranteed to have an erection. And so that probably takes some pressure off during intimacy.
100%. And it takes the planning out of the mix. So many couples spend so much time planning, what did I eat? Can I take a pill? Is it going to absorb? We're traveling. How do I take my medications, which are injections that need to be on ice when I travel? And if I'm with a new partner because I'm a widower, how do I introduce this? And so there's a lot of time planning, and that can be as complicating as just performance anxiety alone.
Yeah.
Uh,
So, what misconceptions do patients have about penile prosthetics, you think, or what are the ones that you've seen?
I think that they're experimental. They are not. They are 50 plus years old. It is not a robotic penis. Nobody will know that they have it. I have a patient who is a psychologist who has never been married, and he came back a year after for follow-up and said he had been dating a new partner for 3 months, and she had no idea he had it. And so until he told her. And so they are discreet. I think people think that it's for the guy that wants to have sex all the time. And sure, it can give him that. But I also have a patient who had prostate cancer. He was also a bachelor his whole life. And he said to me, I may never use this, but if I know I can't get an erection, I'm never going to pursue a partner socially. And for him, if we go back to where we started in this conversation, that sort of filled that gap that was created in his self-identity, his masculine self-identity. And I also have a patient who's 83 with his partner 50 years, who 6 months after came back and he says, we have never been closer in our relationship because for the last 30, 40 years, we've had to navigate this complicated task of being sexually active. And so he says, even if these are going to be the best years of the life I have left, even if it's 2 or 3 years, he said. And of course, he was healthy enough for surgery. We don't just operate on anyone. But I think it's that it is this crude, rude thing that only people who are, sex maniacs or want to be on all the time have done. Real people have them done in their real relationships that are just like everyone else's.
Yeah, yeah, it sounds like it can be really transformational for a lot of individuals. So why do you think, some men will wait years before doing something like this?
I think it's the finality of it. There's one part that we tell people: once you have an implant, you can't use pills or injections or pumps. But it's also that you don't need to. That this overcomes a lot of the limitations of those treatment. But I think it also appeals to men's sense of failure. And this is a recurring theme, is that I couldn't find a solution that my body could repair or fix it myself.
Hmm.
And it's that I need help, or I still want to pursue this, even if it takes this big step of having an operation. And so I think people don't want to cross that bridge until they feel that they have exhausted all their options, when in fact they're really just delaying the solution.
Yeah, yeah, absolutely. I can see how somebody might think of it as a failure having to use a prosthetic.
Hmm.
So, what happens to male sexual function as men age? I'm really curious about that because I know a lot about menopause and perimenopause and sexual function and dysfunction with women, but I don't know anything about male sexual function.
Yeah, I alluded to it before, that 10% increase per year. So 50% of men in their 50s have erectile dysfunction, which means the hardness, the reliability of the hardness goes down. The ability to obtain and maintain the erection goes down. But what also happens is sensation of orgasm changes. Muscles weaken, nerve sensation weakens. And then there's something called the refractory time, that men are able to climax. And as young men, they're able to climax in more rapid succession. But as we get older, that refractory time increases. And then, sort of those same things: body image, self identity. There's shortening of the penis. If the penis doesn't stretch and extend, you get atrophy in the same way that a menopausal vagina will atrophy and the tissues will contract. And so that then affects even the interaction of how intercourse feels for partners, and also self-identity. And so that, and then the same things happening in women with hormones. We see a decline in hormones, not always the absolute number, but the balance. SHBG. There's this protein that mops the testosterone up in our blood. So we may have normal levels, but there's less available for us to get in the mood, and so desire. And then all of the things we've touched on, silence, the miscommunication, the misunderstanding. Sometimes, like, again, getting an erection is mechanical, and it doesn't fix an argument that needs to be resolved. It doesn't fix, a marriage that had problems before. It only fixed the mechanics.
So interesting. So you just said something which I did not know. So you're saying that if a person is not having an erection frequently, that their penis shrinks?
Yes. So men's penises shrink because of aging, and it's the hardening of the arteries. And just like your hamstrings, if you don't stretch them, you will get, tight hamstrings. If you stretch and distend that penile tissue, it keeps the blood vessels healthy. We know that when a blood vessel stretches, it releases chemistry that keeps it healthy. And if you don't stretch it, that chemistry is not there. And so there is a hardening of that vascular tissue, and there is a shrinking. Some men will use stretching devices to restore that. For example, before penile implant, I have men use a vacuum penis pump on a daily basis to just reintroduce that stretch and expanse so that we can restore as much possible length. but invariably men lose length to their penis because of shriveling up or atrophy.
So interesting. I had no idea. So how does testosterone, stress, sleep, obesity, chronic disease affect erections and libido?
Yeah, I think it affects wellness, and in the same way that all of those things are affecting women. Um, but we know that, say, sleep, for example, 5 nights of poor sleep can decrease a man's testosterone level by 10 to 15%.
Oh, wow.
And so men who have low libido and poor erections, we recommend sleep studies. So if somebody has sleep apnea, they're not getting quality sleep, we can actually help improve their testosterone, their libido, and maybe their erections because of that. Sleep, when we sleep, testosterone is produced. And when we sleep, we get our natural cortisol surges. But when we also sleep, we have the chronic physiologic stress of not sleeping, and that affects normal cortisol regulation, which results in decreased testosterone. And then the stress, the fight or flight, the blood vessels that squeeze, the blood vessels that don't expand. Obesity is the symptom of having extra fat. Testosterone is converted to estrogen in the fat. And so when we carry extra body weight, it's called aromatization. A lot of the testosterone that may be made is being shifted. And so that man may have a normal appearing testosterone, a normal appearing estrogen, but the balance, that ideal balance of how much testosterone relative to how much estrogen gets shifted. And then just chronic diseases, things like chronic pain, things like diabetes, arthritis, emphysema. We know that 20 to 25% of men with chronic conditions are also men with low testosterone. And so we can blame age, we can blame the chronic condition for why we feel tired and not interested. But we may also have this other factor of low testosterone or poor sleep or carrying the extra weight. There's a discussion happening now if we treat men with GLP-1s like Wegovy and Zepbound, who have low normal testosterones, can we actually improve their testosterone? And there's data emerging that just managing the weight alone can improve testosterone.
Mm.
Not just the self-identity, not just the physical benefits. And exercise. There's a great meta-analysis published in the last year or two looking at exercise as an intervention. And men who introduce 3 to 4 weeks of moderate exercise, 30 to 40 minutes, where there wasn't that exercise before, can actually have significant measurable improvements in the erection function score that we use to quantify. And what's interesting is the more severe the erectile dysfunction, the moderate guys, not the guys who can't have anything, but the guys who are sort of on that teeter-totter between something invasive and a pill, actually improve more. And so all of these things, it gets back to what's good for the heart. We know that sleep is good for our heart health. All of these things are also good for the penis and our
Mm.
hormones. Yeah.
Yes. So, I do have a quick question though about GLP-1. So I've heard that a mutual colleague of ours, Dr. Rachel Rubin, I know was doing some research on GLP-1s and desire. And, because GLP-1s they kind of get rid of that dopamine rush that maybe people get with food and, get rid of that food noise. Have you seen that? Have you seen maybe a decline in desire with GLP-1s? I don't know, I know they're working on that study. I don't know if it's actually resulted in anything yet.
I think anecdotally, yes, I've seen it described. I think that I think what we're going to see is there's some people who respond in that way and others, but I think there's something there, and I think that those studies are important. I think it gets a little confounded sometimes, though, in the ED itself, right? That the men I'm seeing often are men who already have ED, and that has that's the bigger ball of wax. And we talk about those interventions. I don't know of a lot of urologists yet who are saying, I'm the person that's going to offer that intervention of a GLP-1, but I think we need to be aware of it. And I say, like with any med, like if someone starts a new med and then they have ED, that's the culprit that we think because it's the most obvious change. But when we layer on meds, sometimes it's the thing that tipped a system that was just hanging on. But I think if somebody who had a normal desire, normal libido, within months or weeks of starting one of these medications is experiencing that, I think that is biologically plausible because of what you described, Dr. Rubin's work and others. And this is affecting our dopamine and pursuit of sex is dopamine related. Dopamine's an important part of libido.
Yeah. Yeah. So, how important, and I think you mentioned this already, what are some early signs that sexual symptoms may reflect a broader health issue like cardiovascular disease and diabetes? And I think you mentioned that already with erectile dysfunction and inability to have an erection, and diabetes also affecting erections.
I think it's about pattern. Like I said before, the one off and the occasional that can be described by something else is probably not an issue. But it's really just that pattern. And if somebody is worried about it, and if nothing else, it's really an opportunity to check in about your health in general.
Yeah. Yeah. So, what is one thing every man should know about sexual health?
Um, that they should address it as a health concern, not as a verdict on them. Not as a verdict on how they show up as a partner, even though it's causing them to maybe not show up. It's not a value thing that when 90% of ED is physical, sometimes there's nothing we could have done to have avoided that. And so I think I want people to know that there are people like you, like me, there are resources, like newsletters and good sexual medicine providers, not just supplements, who can actually start these conversations. And reassurance that it's nothing serious is important. And pursuing things that work is also important. There are very few quick fixes in sexual medicine. There are those moments, and I would say an implant for some men is very much a quick fix, even though it requires an operation. But just that getting to the real discussion, the person who can actually help you find the solution, is really the way to move out of the shame and the waiting and the silence and the frustration. And it's not about you. It's about your system. If your car stalls, it's not because you're a bad driver. If it needs work at the mechanics, if your erection doesn't work, it's not necessarily about you. It might be that your body needs a tune-up.
Yeah. Yeah, absolutely. What is one thing every woman should understand about men and intimacy?
That when intimacy fails because of the erection, it's not necessarily about her. And I think it goes back to that phrase, silence is an option. And blame doesn't necessarily nurture the discussion. And so silence is an option, I think. And how we support our partners, it might not be, you don't want to have sex with me anymore. It's just, it might be, I miss being close to you. How can we move in that direction? Those may mean this feel very different, but that second phrase is so much more inviting to say, what's been happening? Because I miss feeling close to you.
Hmm. What's the biggest misconception about aging and sexuality, you think?
That it disappears, that it has to stop, that there is an expiration date on our ability to be, sexual beings. The way we have sex, how we get to successful sexual activity may change. We may need help, as we've talked about. Sex may shift from being all about intercourse to being about a different kind of closeness, a different kind of way to stimulate each other's intimately to get to orgasm. And so it's sometimes just knowing that if it's safe, it's still okay to pursue. Similarly, I think it's important for a lot of couples or men to hear that it's okay to stop pursuing. And I've had men cry when I tell them that, because that's the most relieving thing. But sex doesn't have to end, and sex is about partnership, and when there's partnership, sex is healthier. When there's communication, there was a book I was given. I went to med school in Canada, and there was a husband and wife, a primary doc and a nurse, who had in the 70s did the sexual medicine training, and they wrote a book called Sex is a 13-letter word, Communication.
Yeah, that's great. I'm writing a book too, so I'm gonna send you a copy.
Okay, please do.
Yeah. Okay, so tell me, what gives you hope about the future of men's sexual health?
I think, there's all the technical things that good doctors and good science are doing to make surgery like robotic surgery better, to make implants and reducing some of the side effects or complications with that, or new treatments to actually address maybe reversing some of the age-related changes. And all of that, I think, is good for all of us as docs and the people we care for. But I think it is discussions like this, the discussions that you have all the time on your podcast, because people don't know where. They're either information fatigued and they don't know who to trust, or they don't even know where to start. And 12 minutes in the doctor's office usually doesn't get to the root of sometimes why are you actually here. And so I think it's conversation and information from people who have been there with the experience, that is not hyped, that is tailored to the context of the person sitting in front of us, because that's the only person that matters when I'm having a discussion with that man, is what matters to him.
Absolutely. Absolutely. And, so much of what you had said in this podcast was that things are a choice. And, when you're talking about sexual function or dysfunction, I always say that abstinence is a choice, right? It doesn't have to happen. And specifically as people age, whether it's men or women or whoever, I think that, to be abstinent isn't something that happens as a result of aging. It's a result of a choice, and that there are so many different ways that we can help individuals out as they get older. But, it's something that you should ask your provider about, or, if you're curious, find somebody that can answer those questions for you. And so lastly, if listeners take one message from this episode, just one, what do you hope that is?
Silence is an option.
I love that. I love that. Excellent. Well, thank you so much. This was
Thank
such a
you.
fantastic episode. And as I said before, I don't really talk about male function, dysfunction very much. So this was so enlightening. And so for all those individuals that are watching, that are listening, that are thinking, wow, Dr. Kuan is so amazing and I really need his help, or where can I get more information about him, for him? How can I work with him? How can they do that?
So I mentioned my newsletter, Sex After Retirement. It's a free weekly newsletter. It's www.sexafterretirement.com. And then, of course, I'm on the socials, stepping into that space, and it's at DrJamesKuan, at Dr. James Kuan. And I try to post regularly little snippets about things like this. My goal is to talk to the guy who's sitting on the tractor, in the field at night or in the airport lounge, who just doesn't know where to turn, to give him information and context so that he has choice, like you said, choice to either stay in the status quo, choice to seek out help, or choice to take action, and choice to return or continue to show up in their relationship in the way that's important for him and his partner.
Excellent. Well, thank you so much for coming
Thank
on.
you.
And well, we are done here, and it's been real and really intimate. And remember, this is not meant to be any type of medical advice. If you have any questions about your health or erections or anything like that, please go speak with your friendly neighborhood urologist. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.